Welcome to AETCM. Today I'm discussing about a 53-year-old female who came here with complaints of breathing difficulty and some generalized tiredness. So the 53-year-old female was brought to here with complaints of generalized tiredness, breathlessness, and some generalized rash all over the body since past few days. She was admitted in another hospital, then referred to our hospital for further management. So initial 10-second
When
assessment.
somebody come with a rash to your emergency room, what are the precautions you take? We don't know what is the case. A rash patient coming to emergency room. What are the precautions you take?
One thing, the main thing will be our personal protective equipments. Whoever the patient is attending the patient, whether it's a doctor or the staff, they should be having at least a level 1 or 2 personal protective equipment, which should include at least the gloves should be there, and if possible, like gown or goggles, whatever is available, which we can use. Minimum, we should have at least a gloves and a mask should be available.
So one is personal protection agents, other one is other patients, those who are in a emergency room. No, this case is not an infectious case, but many cases can be infectious, including like meningococcal meningitis.
Exanthematous
We have to be very careful dealing that type of patient. Try to keep it in a separate area, examine with all precautions.
So this patient, I mainly came with complaints of breathing difficulty at that point. So my initial 10-second assessment, she was conscious, oriented, obeying to my commands. I went to the primary survey. Her airway was patent. There was no signs of any obstruction. There was no stridor, gurgling, or any pooling or secretions. Breathing part, she was tachypneic. She had a respiratory rate of about 30 to 36 per minute. Respiratory, she was maintaining only 90, about 88, 90 in room air. So we started on supplementary oxygen with nasal prongs. With that, about 2-3 liters, she was maintaining 98% with O2 supplementation. And on auscultation, she had bilateral crepitations. She had bilateral coarse crepitation, so we also arranged her, to start her on NIV at that point. Circulatory part, she had a heart rate of 76 per minute, and blood pressure was 150 by 90 millimeters of mercury. Distal pulse were equally palpable, and disability part, she had a full score of GCS, and also exposure, she was febrile. GRBS text was 135 milligram per deciliter. On clinical examination, she had ecchymotic patches all over the body, about 2 centimeter, 1 to 2 centimeter patches were there. But there was no history of any like trauma or anything in the recent past. So, primary survey, the only issue was in the airway, not airway, breathing part mainly. She was tachypneic with crepitations, and it could, could be signs of like a lower respiratory infection, or maybe could be an early fluid overload state also. But from a referral history, we know she had some history of acute pulmonary edema in the past, recent past. So we started her on NIV. So currently she is on NIV. She is maintaining.
What are the contraindications for an IV in emergency?
One thing is a low sensorium. She should be able to tolerate the NIV, and also she should not have a GCS drop when you're putting on NIV, because it's a high chance of failure is there. Second is low blood pressure, because again positive ventilation can again drop the blood pressure initially. So this patient hemodynamically she is stable and sensorium is also intact. We started on NIV. So coming to the secondary survey, she was a 53-year-old female.
Slightly high.
About 150/90. So we put her on NIV. Coming to the secondary survey, we took a detailed history. She was admitted about 3 days back in another hospital with complaints of acute onset of some breathlessness and generalized rashes. And also she had 1-day episode of fever. She is a non-case of hypertensive on medications, but no other history. There was no history of any abdominal pain, vomiting, loose stools, or any headache or seizures. And on evaluation, she was found to have low hemoglobin and low platelet, and also altered renal function.
Okay.
And following admission, as the day progressed, she developed worsening of breathlessness and was found to have acute metabolic acidosis. So they initially give her actually anemia correction was given. Then they started dialysis the patient, because she was going into like acute kidney injury and failure.
What is the reason for metabolic acidosis?
Thing is, could be secondary to acute kidney injury. Creatinine went up to 8. And also, they did a peripheral blood smear. It was found to have thrombocytopenia along with microangiopathic hemolytic anemia. It was noted in the peripheral smear. And so, considering her history, they were having a suspicion of it to be like a TTP, thrombocytic purpura. They started her on plasma exchange. So about 7 rounds of plasma exchange was transfused during hospital stay, and also steroids and rituximab was also started during the treatment.
What are the risk factors of risk of what is the risk of plasma exchange like this?
Means on starting or like One thing could be like any patient, she could have transfusion reactions, like transfusion related
You always
lung
think that
injury.
transfusion related lung injury because this patient only received plasma exchange. Normally, plasma exchange will not produce fluid overload in any case. So, if the patient develops a lung injury after plasma exchange, then you have to always think about
Trialing.
trialing.
So this patient didn't have any issues during that time. About 7 times transfusions was given, but renal function was not improving. About 5 times she was dialyzed in the hospital, and about 7 times plasma exchange was given, and she was on steroids and rituximab. But in case of worsening AKU, she was referred to our hospital for further management. So currently she is on NIV. She is maintaining hemodynamically. So we continue our survey. She doesn't have any non-allergic history. She is taking previously only medications for hypertension. No previous surgical or medical history in the past significant. And also her last meal was about 8 hours before coming to the hospital. And there was no any significant recent events. So clinical examination, she is now on NIV, conscious oriented. Chest, she have biologic repetitions. Her tachypnea is slowly improving. S1S2 was heard, there was no murmurs. Abdomen was soft and non-tender. She had a full score of GCS, there was no focal deficits. And we took an adjunct of an ABG was taken. ABG was showing metabolic acidosis. Metabolic acidosis with a pH of 7.26 was noted. And bicar was 13 with a creat of 8.57. She already have a this thing FC placed from another hospital,
Compensated or not?
uncompensated,
Uncompensated.
because 7.26 was the pH.
PaCO2 level.
PaCO2 was 36.
So slightly,
Slightly, she's going for compensation, but not yet there. But anyway, considering her condition, we already arranged informed our nephrologist
What
colleagues
happened
also.
to carbon dioxide levels if there is a metabolic acidosis?
Metabolic acidosis, carbon dioxide will be decreased to compensate for the acidosis occurring due to the bicarbonate decreasing.
How when the like carbon dioxide decreases, how the metabolic acidosis corrects?
Uh, the CO2 combined with the bicarbonate and thereby
What is the mechanism?
So basically, in AK patients, there will be a loss of bicarb causing
Yeah,
like
that I understand.
asthma.
I'm asking how when we are breathing fast in acidosis, how the acidosis gets corrected.
So basically, more carbon dioxide being washed out with every fast ventilation.
So
So the PCO2 level will slowly decrease in the blood.
PCO2 is acidic in nature. So hyperventilation meaning PCO2 gets out. So when PCO2 gets out, the
So the
acidity
serum-
component of the blood goes out. That's how it
what
gets
is that
out.
acidity component of blood?
PCO2. More the
PCO2.
PCO2, more the acidity of the
What is that acid?
carbonic acid.
Carbonic acid. Carbonic
PCO2
acid.
with water that
become
produces
carbonic
acid. If you wash out the carbon dioxide, carbonic acid levels will
go
come
down.
That will
Compensate
correct
for
the
the-
compensate.
This patient, she's trying to compensate, but she's not there yet. So we arranged for a dialysis in ED itself. So with that,
The HB, you told low HB.
HB was 7.9.
Okay, that itself may cause dyspnea. Okay, so all these things should be tackled. So instead of telling just lower, high like that, precise values will give an right thing. Okay, good.
So we send all routine investigations parallelly. We send all investigations and everything. We arrange for hemodialysis in ED itself. On NIV, she is clinically improving. Means her tachypnea, everything is improving, and BP, everything is maintaining. So her reports came like this thing. Lab HP is 8.8, and platelet is showing to be 25,000.
We want to transfuse in this patient hemoglobin.
Hemoglobin 8.8 is the current this thing. But considering her symptoms, it could be secondary to like it could be anemia induced heart failure, could also be a this thing. So we can arrange for transfusion at least to
It is
maintain
better to
above.
correct in this patient at least because she is having cardiac failure. So better to correct in this patient.
So we could at least try to keep it above 10 will be.
Before that, you should know what is the reason for anemia in this patient. Why the patient has developed anemia.
Anemia.
It is due to he has already developed a problem, microangiopathic
Microangiopathic
hemolytic
hemolytic
anemia.
anemia.
So that may be the reason, but since kidney failure is there, that will add because erythropoietin level low. So you have to give erythropoietin, folic acid with blood transfusion may correct this issue.
So with those all arranged, actually we again went with the detailed history. So patient was evaluated outside with this anemia with AKA, and also she had some septic component. Her on initial arrival, her inflammatory markers were elevated. She was on multiple this thing antibiotics, mainly on piperacillin, tazobactam, and so this thing is so basically she has got anemia, thrombocytopenia, acute kidney injury, and urinary tract infection. These things were diagnosed from another hospital, and for this further evaluation of Maha MHA, so they found to have she having very low ADAM TS13 factor. So they were suspecting her to have severe thrombotic thrombocytopenia in purpura. So that was the rationale behind starting her on plasma exchange.
Basically, what are the two types of TTP?
One will be immune.
One will be congenital. The problem starts from the younger
birth
childhood itself. But this patient is adult. She never had this history, no? First time she is
First
coming.
time she is having this history.
So what is the reason for that? What may be the reason for that?
Could be acquired.
Acquired
Like secondary to infection or
infection
sepsis.
itself can produce. Sepsis is one of the major reasons for secondary TTPs. There also you can get this Adams 13 is low.
Low value. So this patient, they had not only the initial evaluation, and they were suspecting it to be like a TTP, so they started her on plasma exchange.
Okay.
But her counts, everything was still persisting, so they referred.
Why not it is HUS, hemolytic uremic syndrome?
HUS could also be a possibility, but this thing, sepsis, common. No.
HUS is almost similar.
Almost
Only
similar
thing
to
is
this
what
thing
you
only.
have done is Adams 13 level is low here. HUS, the major difference is HUS will have predominantly renal failure, but TTP it is less common. Here the patient is already having renal failure also. Here neurological findings are more common in TTP, but that is less in HUS. But here there is no neurological
finding.
But only favoring thing is here TTP is
Low
Adams 13. Okay, that is the only thing which favors this condition. What is this microangiopathic hemolytic anemia? What is the reason for that?
This patient?
Both in HUS, TTP, you have microangiopathic hemolytic anemia. How do you know that it is immune or non-immune?
We can do a Coombs test.
Coombs test. What is a Coombs test?
In this one, Coombs is negative.
Negative. Coombs will be negative in both these conditions. So there is an Evans syndrome. What is Evans syndrome?
Evans syndrome,
there is immune-mediated thrombocytopenia, immune-mediated hemolytic anemia. There Coombs will be positive.
So when we are suspecting like a probable this thing TTP, we have a plasmic score, a system which we can use to decide whether to give this thing exchange or not. So there are multiple this thing. One is platelet count less than 30,000. Then another is one or more indicators of hemolysis, like a low reticulocyte count, or maybe haptoglobin is not detectable, or indirect bilirubin more than 2. And also there is no history of any recent or any active cancer history in the past or in the recent present. And also there is no history of any solid organ or any hematopoietic stem cell transplant recently. And also the MCV is less than 90 and INR less than 1.5, creatinine less than 2. So if you're getting calculating the values, if it is in the coming under intermediate or high risk, that is low risk is 0 to 4, 5 is intermediate, 6 to 7 is high risk. So if it is coming under 5 or above, we can think about giving transfusion in ED itself. Because TTP is a medical emergency which we have to consider giving this thing, transfusion in ED itself. The
problem is thrombocytopenia. Why don't you give platelet transfusion?
This again can worsen the condition.
Can worsen the condition. How do it worsen the condition?
So basically, TTP is actually there are autoantibodies against the this thing. Von Willebrand.
It is not autoantibody. It's an antibody.
Antibody.
Autoantibody means our body is producing without any trigger. So autoimmune disease as a selling. But here antibodies are produced. Some are due to trigger. Some are not due to trigger. It's a primary this one TTP. It is an autoimmune disease. But here secondary, it is due to some other trigger.
May have triggered
molecular mimicry. So that produces antibodies. So they are not auto-antibodies, but it is definitely the mechanism is same. They are antibody-mediated destruction.
So even if we are giving transfusion, it may not help the patient. So the treatment option mainly
it can even aggravate the problem. Patient mortality is very high in patients who received transfusions.
So basically, what happens is whenever there is TTP, and there are actually small thrombins forming in the microvasculature, mainly comprising of this thing platelets, and it is again secondary to like low Adam 13 means actually there are antibodies against the Adam 13 value, this thing component. So treatment options we have in ED will be the most important will be to give transfusion of plasma. Plasma we can mainly go for FFP or even cryo minus plasma is also can be used, but the preferred one is FFP. FFP we usually give 40 ml per kg is the recommended dose, and preferably we go for a like a central or like a large vein catheterization is preferred. So that is the primary this thing we can give in ED, and also our goal will be to give continuous transfusions until the patient shows improvement in his platelet count. So we may have to
It
continue.
is not transfer, it is a plasma exchange. You have to remove
So
whatever.
we have to remove the antibody containing plasma on one side, and same time we have to introduce the donor plasma on the other side. So it's almost like a dialysis. In one way we remove the plasma, and other side we introduce the donor plasma. So this process is continued. The endpoint of treatment will be like the once the patient's platelet count starts showing improvement, also it starts becoming clinically better. And also to supplement the treatment, we can also start him on steroids, and rituximab can also be started. Suppose the patient is not able to take plasma for any reason, we can also start on other therapies which we have available. One thing will be like an multiple these things are there. Antibody. So that I will tell you. So multiple drugs are available which we can use instead of plasma exchange.
Rituximab.
Rituximab.
Anti-CD20.
So a patient coming to ED with complaints of generalized rashes or maybe like low hemoglobin or low platelet, our initial approach will be like to start like any patient. We go with ABCD, initially stabilize the patient, correct any acutely correctable factors, and then we go for evaluation. Evaluation will be initially we go for.
You had told history is very important. History, in HUS, hemolytic uremic syndrome, how the history different from TTP?
The main thing will be in TTP the kidney component may not be predominant.
Here, but it is there. So
It's there.
Difficult. So how do you differentiate then? One is it is very common in children, HUS.
HUS.
Second thing is it is post diarrhea mostly. It is due to Shigella or E.
Shigella
coli.
toxin induced.
So that is very common. Diarrhea is very common. It is common in children. Here there is no pre-existing history of any diarrhea like that. It can be there in sometimes, and it is more common in adults.
So this patient's only history was some mild breathlessness and this thing only. Okay. So initial evaluation, we will be sending the patient for our routine blood investigations to look for a complete blood count and thrombocyte, this thing, platelet count, everything. Along with that, we go for a peripheral smear. Peripheral smear, we look for the nature of the RBCs and platelets, whether we have like what do we call hemolyzed platelets in RBCs or like microcytic or hypochromic RBCs, anything we have to look in the peripheral blood smear. So in patients like this one, they will be having like hemolyzed RBCs will be present in the peripheral blood smear, which will be having features of microangiopathic nature. So what we are suspecting is basically in the small arterioles, microvasculature and capillaries, there is actually hemolysis happening due to some reason, which is mostly non-immune mediated. So it could be secondary to like platelets clumping in those microvasculature causing rupture of these platelets. So these patients will be coming with complaints of both thrombocytopenia along with anemia. But the treatment plan will be not like in any patient replacing the component, but we have to treat the actual cause of this thing, which may not be able to correct, but we can treat it with replacement of plasma. So before going for like you're terming it like TTP, we have to rule out other causes of TTP. It could be like acute infection, any sepsis, which could be secondary to bacterial, viral, or even fungal infections can cause a similar picture. Or maybe like an acute kidney injury secondary to accelerated hypertension, or maybe secondary to preeclampsia. If especially the patient is in a pregnant lady, we have to think about HELP syndrome, which again can appear with similar picture. Also in case of any malignancy. So all these conditions need to be.
But young female coming with this, what else can be there? What else you'll suspect?
Other than HELP.
Your patient is not pregnant. What else can present as all these complications? Which other disease can present? SLE is
SLE.
most will be part of SLE. SLE is one of the important condition we should remember. It can present like anything. Even without the skin manifestations, SLE can present with autoimmune hemolytic anemia, microangiopathic hemolytic anemia, TTP. So many variations can occur in SLE induced problem. So always you have to do ANA and DSDNA. ANA alone will not tell you that patient is having SLE or not. DSDNA or other investigation autoimmune
On that spectrum.
that has to be ruled out.
So that again can be one of the.
What is the procalcitonin in this patient?
Procalcitonin was 89.
That means there is strong infection.
Strong infection is
The
also
cause may be infection itself here. So controlling the infection can bring back the patient.
So this patient, we started her on like high-grade antibody. Initially, she was started on meropenem. Along with we continued her to give plasma exchange was continued in our hospital also. Along with that, we gave continuous hemodialysis because actually her creatinine was not her renal parameters were not improving in the initial stages. So multiple hemodialysis were given. Rituximab is also being continued. So currently she is clinically improving. Mainly her inflammatory parameters are coming down. She is actually weaned off NIV. She is on supplementary oxygen right now, and clinically improving.
Okay.
So
What is the basic difference between steroid and monoclonal antibodies like rituximab here?
rituximab is usually started when we have a
What is the
definitely
basic
diagnosed.
difference between a steroid and a non-steroidal anti-inflammatory like
Rituximab.
drugs like rituximab or any other MABs? MAB is monoclonal antibody.
They are more specific.
They are more specific to some targets. Target-oriented therapy. Here it is CD20. And some other drugs, different CDs, it will act against that. So, steroid has a general suppression of immunity. Here it suppresses only that part of the immunity. Okay. So, some T cell immunity, B cell immunity, like that, it targets only specific cells. So, they are better than that steroid, but it is very costly. Side effect wise, they are better than steroids.
Well, it is a flare of the infection also. So as we discussed earlier, so initial approach to a patient after the hemodynamics and the blood parameters, we are suspecting patient is to be having TTP. One thing we'll be going for is the plasmic score, which can give a probable chance of TTP. And if it's coming anything above 5, we think about starting infusion in this thing plasma exchange in ED itself. And also at the same time, if available, we go for parallelly testing for the Adams TS13 level value should also be tested. And almost any patient, there is not much contraindication for starting therapeutic plasma exchange in ED itself, which will be because if untreated, the patient's progression course can go acute worsening very fast. It will be seen as neurological deterioration. The patient can have acute worsening sensorium and all that, and also cardiac ischemia because of the thrombotic occlusion of the coronaries, and also irreversible renal failure and even progressively death can also happen in ED itself. So whichever patient is having even a moderate suspicion of TTP, this TTP, we started on plasma exchange because it can be life-saving. So the other options we have, one is glucocorticosteroids. If the patient is having a mild to moderate status, we go for oral prednisolone as the initial treatment of choice. But patient is actually sick or in a moderate to severe category, we go for IV methyl prednisolone, MPS, or MPS will be the drug of choice. And also rituximab is again given in almost all patients once the diagnosis is confirmed. But if you're not able to confirm also, if the patient is coming in a severe category of the plasmic score, we start on rituximab as early as possible. Now we recently have one more drug which is caplacizumab, which is more like targeted therapy. It is mainly indicated for patients who are we are planning to give aggressive initial management, especially in case of high risk patients. So the patient, this thing is actually an anti-von Willebrand factor therapy. So especially indicated in patients who are presenting to ED with complaints of neurological abnormalities like focal seizures or maybe dysarthria, confusion, or even coma. This kind of patients, we can start the patient on this caplacizumab in ED itself if available. So our treatment plan will be to support all the hemodynamics, and also if the patient is having associated AK or any other infective pathology, we support or treat that component. And this plasma transfusion or exchange is continued until the platelet count comes above 1.5 lakhs. because until then this thing is continued, because the patient can again have a relapse at any point even during therapy. So if the patient is having relapse, this treatments again continued until the patient clinically improves, or the basic parameters comes to like almost a normal range. And also the patient's cardiac status should also be continuously monitored by early echo, and also like follow up on that, because the patient cannot have any time this thing cardiac complications also. This patient also, about 7 days post admission, she developed some chest discomfort and was found to have elevated this thing, cardiac enzymes with some RWMA. So it's this thing of AC sensitivity was also diagnosed during our treatment in hospital.
Is it due to myocardial infarction or ischemia of myocardium due to sepsis?
It could be one thing is it could be secondary to sepsis induced this thing, ischemia, or maybe like a thrombotic complication also.
So the more common chance is for a sepsis-induced hypoxemia-induced myocardial injury, but in TTP there is a high chance of myocardial infarction due to this block
Thrombotic,
itself, thrombus itself.
So anyway, she was managed conservatively for that also. So multiple routes have been done for this patient. One is our treatment plan was mainly to control the sepsis. So we started on high-grade antibodies with meropenem, and we initially started the patient on. Her this thing culture came to be positive for this thing MDR E. coli, but sensitive to meropenem. So the drugs being continued. She had almost 5 to 6 sessions of dialysis in ED, and about a total of 16 transfusions of this thing plasma has been given. Comprising both the other outside hospital and our hospital, 16 transfusions have been given, and currently the platelet count has come up to 90,000. But she doesn't have any bleeding manifestations or anything. Hemodynamically, she is maintaining. And also this AC sensitivity and all, considering that we already started the patient on ecosprin, which is being continued, and so rituximab and also steroids have been stopped, but rituximab is being continued right now. So overall, the patient is clinically improving currently.
What are the drugs which can be used?
Cause thrombocytopenia. One thing is, especially in hospital, we start the patient heparin as DVD prophylaxis. So which again can heparin-induced thrombocytopenia is one of the first things to think about. Then
Very common.
NSAIDs, especially for pain, if you're giving NSAIDs, it can again cause thrombocytopenia. Then
Sir, usage of antiplatelet agents in such
but
cases.
it will not cause reduction in this one, but antiplatelets are actually recommended in TTP because thrombotic complications are more, because these patients conservatively also we can start aspirin on the initial stage itself. So this patient we already started because even before she had instantly we started her on ecosprin on the initial day itself.
See, what are the precautions you will take in such cases when you opt for an intubation?
Intubation. One thing is this thing. She has got high chances of bleeding. Tendency is there. So whatever maneuvers we are doing, we have to go as gentle as possible.
As gentle as possible.
And also, if the patient is actually in an acute hemodynamically unstable state, we have to like initially stabilize her at least for this thing to compensate for the drugs which we are giving. So we have to go for
anesthetic agents. Selection.
So we have to go for like hemodynamically stable drugs like etomidate or clonidine or something, so that patient may not go for again further compromise.
Okay.
And also when we are maneuvering the patient, this thing always go for the correct tube and correct distance size, so that
near traumatic.
So it will be as traumatic as possible. And also if we have access to video laryngoscope and anything, which we can use that
including
also.
Usage of suction catheter.
Suction catheter.
And other catheterization, everything. Okay.
And also we go for like complete paralysis and all before intubation. So we not like go for any subsedation or anything. We go for complete deep sedation and paralytic before going for intubation.
Okay, good.
Anything else you want to add? Okay, thank you.
Thank you.